So let's discuss about the inguinal and the femoral hernias. To know about the inguinal and the femoral hernias, first what we're gonna do is we're just gonna learn about a little bit about the inguinal hernias, and then we will move toward the femoral hernias. But to know about the inguinal hernia, you should know a little bit of the anatomy. So we will talk about a little bit of the inguinal canal and the surrounding structures which are located in this canal. As you can see in this picture, this is the abdominal wall, and you can see here that this is basically the scrotum, and the testes are within the scrotum. But what happens that in the early childhood, what happens that the testes are located in the abdomen. They're not located in the perineum. So that's why they are in the lower part of the abdomen, but they migrate from the abdominal wall down to the scrotum. Why it happens? Because testes actually they need a little bit of cooler temperature as compared to the rest of the abdomen. So that's why the scrotum, it actually provides a cooler environment for the testes. So the viability of the sperm, this is very much necessary. So the testes should be moved down from the abdominal cavity into the perineal cavity or into the scrotum. So here in this picture, you can see here, this is the abdominal wall with the contents. You can see the gut wall here, and then down, this is the scrotum, and within the scrotum, this is the testes and the epididymis as well. But what happens, like you can see here, these are the intestines, this is the abdomen, and these are the testicles as well. And testicles are enclosed in a pouch which is called a scrotum. But what happens into the inguinal hernia, into the scrotum, you can see here that there is a defect in this abdominal wall. And what happens that actually these are the intestinal loops, and they goes down from this basically this defect, which is the deep inguinal ring, and it goes down into the scrotum, and the patient present to you with the inguinoscrotal swelling. This is another type. Sometimes what happens that if the defect is just in the superficial inguinal ring, in the Hasselbeck triangle, then it would be a direct it would be a direct inguinal hernia, and it will not come into the scrotum. It will be just above in the inguinal region. So basically, there are two different types of the inguinal hernias. One is a direct inguinal hernia, and the other is the indirect inguinal hernia, right? But how you can appreciate between a direct inguinal hernia and an indirect inguinal hernia, we'll talk this later in the lecture, right? For that, you can see here, this is indirect inguinal hernia. Actually, we say that the indirect hernias are lateral hernias because they are coming from the deep inguinal ring. Now, for that, you should know what is a deep inguinal ring. Actually, what happens that there's a defect in a fascia transversalis. You can say that there is a weakness in the fascia transversalis, and that deep inguinal ring is that particular defect which is located in the fascia transversalis. But what happens that for that you should know the landmarks, and the landmarks are anterior superior iliac spine and the pubic tubercle. And you can see that the deep inguinal ring that lies between the anterior superior iliac spine and the pubic tubercle, that's basically the midway between the anterior superior iliac spine and the pubic tubercle, just 2 to 3 centimeters just above and medial to the inguinal ligament, and above and medial to the femoral artery, right? So that's a deep inguinal ring. So this is the indirect hernia, which is coming from the deep inguinal ring going down to the superficial inguinal ring. Actually, there are two rings which are present in this perineal cavity. One is basically the deep inguinal ring, which is a defect in the fascia transversalis, and the other is a superficial inguinal ring, which is located just below this deep inguinal ring, and it is a defect in the external oblique aponeurosis, right? So you can see here that this is that particular ring, And actually this ring is in communication with the anterior abdominal wall. So what happens that when this is a defect, basically there are two types of the inguinal hernias. One is a congenital hernia and the other is a acquired hernia. Most of the time the indirect inguinal hernias, which are coming from the deep inguinal vein to the superficial inguinal ring, they are basically the congenital, because you know that these rings are actually congenitally present because of the defect or the weakness in the fascia transversalis or the aponeurosis of the internal oblique, right? So basically these defects are here, and it goes down into the scrotum as well, and the patient present to you with a swelling in the inguinoscrotal swelling. But that was about the indirect inguinal hernias. But in case of the direct hernias, what happens is there is a basically what happens that when the testes, they move down from the abdomen to the scrotum, they pull a layer of peritoneum with them, and when this most of the time this layer is called as tunica vaginalis. But what happens but in the later developmental stages, this layer of the tunica vaginalis, it goes off, but sometimes it remains there, it persists there, and because of this persistence, the abdominal contents actually they herniate through this defect in the Hasselbeck triangle, which is from the tunica vaginalis. So that's called as a direct hernia. The indirect hernia is more lateral because it is lateral to the inferior epigastric vessels, and the direct hernia is medial because it lies medial to the inferior epigastric vessels, right? So if we talk about the inguinal canal and we talk about the anatomy of the inguinal canal, actually inguinal canal is a very, very important passage. It provides a passage to basically to the structures which is passing from the abdomen deep down into the perineal cavity. What kind of the structures? There are different structures which are passing from this canal in the males, and there are different structures which are passing from this canal in females. But in males, what kind of structures are passing? Testicular artery, testicular vein, the lymphatics, and the vas deferens. Basically in females, round ligament of the ovary and the round ligament of the uterus, these are the two important structures which are passing from the inguinal canal in the females. So these are the two different structures, and I have told you the function of the inguinal canal because it acts as a passage or a route to pass the structures from the abdominal cavity into the perineal cavity. But to know about the little bit of the landmarks of the inguinal canal, actually anterior to the inguinal canal, you have the inguinal ligament, posteriorly is the fascia transversalis, and deep down is also the lacunar ligament, right? So basically these are the hernias. There's another type which is called as a sliding hernia. One was the indirect hernia, other was the direct hernia, and the other one is a sliding hernia. The sliding hernias, they're also the lateral hernias. They're like the indirect hernias, but mostly the indirect hernias, they are congenital. They're not acquired, but the sliding hernias, they are actually sometimes there's a defect or the weakness in the abdominal wall, and what happens that the contents, most of the time the peritoneal fat, it goes down from this defect which is present in the abdominal wall. It goes down here, and sometimes when more of the tissue goes down into the hernia, it pulls off the peritoneum with it, and that's why that's called a sliding hernia, because the contents of the peritoneum, or you can say the peritoneum itself, is slided by that particular peritoneal fat which is present in the hernia. It goes along with that, so that's why it's called as a sliding hernia. So far we have discussed about the indirect hernias, we discussed about the direct hernias, we've discussed about the sliding hernias. Indirect hernia is the lateral to the inferior epigastric vessels. It's most of the time it's actually congenital, and the direct hernias, they're most of the times medial to the inferior epigastric vessels, and they are acquired. Direct hernia is coming from the Hasselbeck triangle, and the indirect hernia is coming from the deep inguinal ring. It actually goes from the deep inguinal ring to the superficial inguinal ring, and then it moves down into the scrotum, right? So this was about, you can see here, indirect hernia, it's coming from the deep inguinal ring, and from the superficial inguinal ring, it going down into the scrotum. Direct hernia is not coming into the scrotum, it's just in the inguinal region, and it's basically in the Hasselbeck triangle. And the sliding hernia is actually sliding the peritoneum with it into the scrotal sac. So these are about the types of the inguinal hernia. So now if we talk about, for that I have already discussed about the superficial inguinal ring and the deep inguinal ring. This is actually the opening to the inguinal canal, which is a superficial inguinal. This is a deep inguinal ring. This is a superficial inguinal ring. Deep inguinal ring is a defect in the fascia transversalis. This is the inguinal canal, and already told you the inguinal canal is very much important because there are different structures which are passing from this canal, from the peritoneal cavity into deep down into the perineal cavity. So that's why this is very much important. In males, we have the testicular artery, we have the testicular vein, the lymphatics, and of course the obviously the vas deferens in the males. But in females, it's the round ligament of the ovary and the round ligament of the uterus, which is passing down from this inguinal canal. You can see here, these are the inferior epigastric vessels. Already told you, indirect hernias are lateral to the inferior epigastric vessels, and the direct hernias are medial to the inferior epigastric vessels. So this is a superficial inguinal ring, which is exit from the inguinal canal, and this was about a little bit of the anatomy. Now let's just talk about the classification. You can either classify it in three different there are basically three different types. If we talk about the classification of the inguinal hernia, one of the primary or the recurrent hernias. Now, what do you mean by primary or recurrent hernias? Primary are basically the congenital hernias, or maybe they're just, the primary means that they are herniated, or the hernia is actually developing for the very first time. But the recurrent hernias, they are developed, they go off, then they're developed again and again. So there is a recurrency in those hernias, and they call the recurrent hernias. So one entity is a primary hernias, which are developing for the very first time. And most of the time, if we talk about the deep, if we talk about the indirect hernias, which are coming from the deep inguinal ring, they are basically the congenital hernias. But if we talk about the recurrent hernias, they are coming, actually they're most of the time acquired, because there's already a potential wall weakness, and because maybe there is an increase in intra-abdominal pressure, there's coughing, there's absolute constipation for a very long time, or there is an increase in intra-abdominal pressure. These are all basically the causative agents which are causing further recurrency of the hernia. The other thing is lateral, medial, or femoral hernia. Actually, one are the inguinal hernias, and the other entity is a femoral hernia. The inguinal hernias are above and lateral to the femoral artery, right? Or you can say above and lateral to the pubic tubercle. So the inguinal hernias are always above and lateral to the pubic tubercle, and the femoral hernias, they are below and medial to the pubic tubercle. So this is basically important entity. And the other things, but if we talk about within the inguinal hernias, there are lateral hernias, there are medial hernias. Already told you that the indirect hernia is a lateral hernia, while the direct hernia is a medial hernia, because it's coming medial to the inferior epigastric vessels, and an indirect hernia is coming lateral to the inferior epigastric vessels, right? And the third thing is a defect size and finger breadth 1.5 centimeter. Actually, that basically depending upon the defect, which is maybe defect can be small, very small, maybe 0.5 centimeter, maybe 1 centimeter, or maybe 1.5 or more than that. So actually, these are three different types of classification: primary or recurrent hernias, lateral, medial, or femoral hernias, or the hernias in which the defect size in finger breadth is actually like 1.5 centimeter. So this was about the classification, but let's discuss about the diagnosis. Again, whenever you're going to make a diagnosis about a certain disease, you'll ask some points in the history, and then you'll take the examination, and then obviously you'll move on forward towards the investigation. So if we talk about the history, a typical patient is coming to you with a history that there's a swelling in my lower abdomen, or maybe he'll say that in the groin region. He'll present to you with a swelling in the groin region, and he will narrate you that whenever I am in a standing position, most of the time the swelling is very much visible, and when I lie down the swelling goes off, and maybe the patient, most of the time the hernias are not painful, but when they're obstructed, when they are strangulated, the hernias are very painful, and the patient can present to you with a painful swelling. Most of the time they present to you with a painless swelling, but sometimes when they're strangulated, when they're obstructed, the patient comes to you and complains you that there is a painful swelling in my groin, right? What you have to ask the patient in the history. Age of the patient is very much important, because mostly the inguinal hernias are very much common, especially the indirect hernias. They're very much common in the old age, mostly males, and they're very much common in the old age people as well. And direct hernias, there's more chance of strangulation as well, but the indirect hernias, there's less chance of the strangulation. So you have to ask about the age of the patient. You have to ask about if he is a smoker or not, or you have to ask about the history of prolonged constipation, absolute constipation, or coughing or straining. You have to ask about all these things, because coughing, straining, they actually increases the intra-abdominal pressure, and because of that there's a more chance to herniate the contents from that defect, right? So you have to ask the patient. These are important things which you will be asking in a patient who's coming to you with the groin swelling. Sometimes it's a painless, but sometimes it's a painful swelling. Now, how you are going to examine a patient who is coming to you with a swelling in the inguinoscrotal region, or maybe in the groin region, right? You have to examine the patient. You have to look for any visible swelling if it's present, and you have to examine the patient in an upright position, in a supine position. Sometimes the swelling is more visible in upright position, but whenever the patient is lying supine, the swelling goes off, right? So you have to examine the patient in both of the positions, in supine position and in standing position as well, right? And then you will have to ask the patient to cough. You'll have to look for the cough impulse. If the swelling is prominent, the cough impulse is positive, and if the swelling is not prominent, even with the coughing, this cough impulse is negative. Most of the time, the hernias which are reducible, they have a positive cough impulse, right? I'm repeating again, most of the time, the hernias, which are basically reducible, they have a positive cough impulse. But the hernias, which are irreducible, which are obstructed, or which are strangulated, most of the time, they have a negative cough impulse, and the swelling is already irreducible. So first thing, you're going to inspect a swelling. You look for any dilatation, visible dilatation or visible bruise. Sometimes it can be traumatic, right? It can be a traumatic hernia, or it can be because it can be hydrocele, it can be saphenaveric. So you have to actually look for all these things. It can be a epididymoarchitis, which is tender. So actually you have to examine the patient, keeping in view all the diagnoses. It can be a hernia, it can be infective process, process, it can be epididymoarchitis, it can be a saphena varix. So you have to look for all these things in your examination findings. You have to examine the patient in upright position, you have to examine the patient in a supine position, you have to ask the patient to cough, and then you have to look for the cough impulse. The third thing you're going to perform is you have to check the reducibility of, you have to push, actually sometimes there is a reduction in the hernia passively, and sometimes you have to reduce the hernia actively. Now, what does that mean? Like sometimes the patient is in a standing position, in an upright position, the hernia is more visible. But when he lies down in a supine position, the hernia goes off. So that's a reducible. That is passive reduction of the hernia. Now, what is the active reduction of the hernia? Actually, you push the swelling inside, and you actually apply a gentle pressure over the swelling, and it goes off. That is basically the active reduction of the hernia. So also you have to perform these things. Now, sometimes this is actually the reduction of the hernia, and you try to palpate. You try to push these contents into the hernia. So this was about the history and examination of a patient who is coming to you with the hernia or with the inguinoscrotal swelling. But there are certain investigations. Mostly, you can make a diagnosis by your history or by the findings of your examination. But sometimes it happens that you are very much confused and you're not sure about, because even after performing the test, like the ring occlusion tests, these are very much important actually. The ring occlusion tests are very much important to distinguish between a direct and an indirect inguinal hernia. What happens that you, in the ring occlusion test, you first occlude the deep inguinal ring, which is located between the anterior superior iliac spine and the pubic tubercle. That's the midway, right? So what you do is you put your thumb over the deep inguinal ring and you ask the patient to cough. If the swelling is not coming from the deep inguinal ring, then the cough impulse would be negative and the ring occlusion test would be negative. But sometimes actually the swelling is coming from the deep to the superficial inguinal ring, and you occlude the superficial inguinal ring, right? You occlude the superficial inguinal ring and you ask the patient to cough, and then the swelling actually comes off from superficial inguinal ring. So that's how you can differentiate between a direct inguinal hernia and the indirect inguinal hernia. But actually, most of the time, the diagnosis is based on the history and the clinical examination. But sometimes you need to go for some of the investigation when your findings are not very conclusive. You go for the ultrasonography. You can see here, you can see a hernial wall. This is basically the hernial sac, and sometimes you don't know, like the hernia has a fat, or maybe the omentum or the inguinal contents, or maybe the peritoneum in it, or the bowel, maybe the small bowel or the large bowel. But in ultrasound, you can see here, actually this is the hernial sac, and you can see the intestinal contents as well in the hernia. You can also go for a CT scan. This is also this is basically the hernial sac here. You can see here, you can also appreciate that the intestine is coming into the sac. So CT scan. And the other thing is that most of the time you need, sometimes what happens that you have a swelling and you try to perform a cuff impulse and the cuff impulse is negative and the swelling is mostly irreducible, and so that can be a malignant mass of the nodes. Sometimes you actually you're confused between a strangulated obstructed hernia and a malignant mass of the nodes. So to differentiate that, actually you can go for the CT scan or you can go for the ultrasonography, because the findings of your examination are conclusive. If the hernia, if there's a negative cuff impulse and the hernia is also reducible, it can be obstructed strangulated hernia, or maybe it can be a malignant mass of the nodes. So to differentiate that, you have to look for the we have to move for some other investigations, maybe the ultrasonography and the CT scan as well. So, if you talk about the differential diagnosis, it can be a spigelian hernia, it can be a saphenavarex, it can be a femoral hernia, and it can be a varicocele. Now, I have to tell you what is a spigelian hernia, what is a saphenavarex, what is a femoral hernia, and what is a varicocele. Actually, spigelian hernia is actually a defect. It's coming from the transversalis fascia as well, and the transversus abdominis muscle. It's actually in the lateral border of the internal, you can see this is basically the median raphe, and this is basically the linea alba, and it's coming from the lateral border of the rectus sheath. So a spigelian is coming from the spigelian fascia, and the spigelian fascia is actually the fascia which is formed by the union of the internal oblique and the transversus, which are basically the innermost layers. Like if we talk about the abdominal layer, you have the skin, you have the superficial fascia, and then you have the subcutaneous tissue as well. Superficial fascia, you have the external oblique epididymosis, then you have the internal oblique, and then you have the transversus muscle, transversalis fascia, and deep down you have the peritoneum, right? So the spigelian hernia, actually between the innermost layers, which is the internal oblique and the transversus abdominis muscle, there's a fascia which is a spigelian fascia, and that hernia is coming from that because that fascia is very thin, and it's a site for the potential weakness. So the spigelian hernia is coming from the spigelian fascia, and the spigelian fascia is actually lying lateral to the rectus border. So you can see here, this is the median midline raphe, or the linea alba, and this is the rectus sheath. So it's coming from the lateral border of the rectus sheath, so that, but it's coming actually from the spigelian fascia, but it's actually located lateral to the rectus muscle or the rectus sheath. So that's a spigelian hernia. So if a patient is coming to you and he's complaining about a swelling in this groin region, you can confuse, or the differential diagnosis should include a spigelian hernia. There can be a saphenavarex. So actually, a saphenavarex is a dilated vein which is located in the groin region in the femoral triangle. So you can also differentiate, you can also think about a saphenavarex as well, but you have to differentiate a spigelian hernia, a saphenavarex, or because veins are mostly they're compressible, so whenever you put the pressure over there, the swelling is compressible, so you can differentiate it. You can always go for the ultrasonography or CT scan, and there you can find out like it's a saphenavarex, or it is basically the hernia. Or there can be a femoral hernia, but the mostly femoral hernias are below and lateral to the pubic tubercle, while the inguinal hernias, they're above and medial to the pubic tubercle. Above and lateral to the pubic tubercle, and femoral hernias are below and lateral to the pubic tubercle, right? And there can be a varicocele as well, because varicocele is that's basically a dilatation, and because of the tunica vaginalis, there's a fluid accumulation, and the fluid from the peritoneal cavity actually that goes down from that tunica vaginalis into the scrotum, it forms a varicocele. So you can have you can think about a spigelian hernia, you can think about the saphenavarex as well, you can think about a femoral hernia, and you have to put the varicocele in your differential diagnosis as well when you are looking for a swelling in an inguinoscrotal swelling, right? Now, examination of the scrotal contents, already told you have to exclude the other pathologies as well, because you have to appreciate if the swelling is coming from the groin region or the swelling is going down into the scrotum region, because most of the time most of the time the direct hernias, they don't come into the scrotum, but the indirect hernias, which are coming from the deep inguinal ring to the superficial inguinal ring, they actually goes down to the scrotum as well. So you have to examine the scrotal contents as well. You have to look for the testes, testes. You have to look for the bilateral testes as well. You have to look for, because sometimes the testes are undescended, so you have to look for the scrotal contents as well. You have to exclude the other pathologies already told you about. You have to exclude the epididymoarchitis, you have to exclude the saphenous varix, you have to exclude the femoral hernias, you have to exclude for the spigelian hernias as well. Now you have to, already told you, you have to check the patient like for both the testes, because sometimes the patient present to you with undescended testes as well. And you have to examine the opposite side as well, because if you're examining, because sometimes there are bilateral hernias as well. So whenever maybe there is a small hernia, maybe the patient didn't notice that well, maybe he has a prominent hernia on one side, but he also have hernia, which is basically the occult hernia. So you have to look for the opposite side as well to make a particular diagnosis. And if there's an opposite hernia, you have to repair bilaterally. You have to repair the first one, and then you have to repair the second one as well. So you have to look for the both sides. Investigations, already talk a little bit about the investigations. You have to go for the CT scan, you have to go for the ultrasonography, and you have to go for the MRI. But these, most of the time, the hernia is basically, you make the diagnosis with your history and your clinical examination. But when you're confused, rather if it's a hernia or it's a malignant mass of the nodes, or it's a saphenous varix, or maybe a varicocele, sometimes you have to go for the ultrasonography, because if there's a varicocele, you can see the free fluid, and you can also appreciate the contents of the hernia. If it's a fat, or it's the bowel is coming into the, most of the time, the direct and the indirect hernia, they contain the intestines as well. So you can appreciate it on CT scan, ultrasonography, and MRI as well. So the management strategies actually depend upon the clinical presentation of the patient. If a patient is coming to you with a pain and discomfort, obviously the management strategies are different. And if a patient is coming to you with a growing mass, the management strategies are different. If there is a pain and discomfort, and there's no palpable mass, you have to go for the radiological investigation. You have to go for the CT scan, you have to go for the ultrasonography, or you have to go for the MRI. And if the patient is asymptomatic, and if there's only a growing mass, you have to discuss you have to go for the conservative management, right? If there is pain and discomfort, and there's no palpable mass, and there is no evidence of hernia, then you manage it conservatively, right? If there's pain and discomfort, there's a growing mass, you go for the surgical repair. And if there is basically evidence of the hernia, you also go for the surgical repair as well. If the conservative management for asymptomatic growing mass, it's basically failed, or the patient becomes symptomatic, you have to go for the surgical repair. So the management strategies about the hernia, that depends upon the clinical presentation of the patient. If the patient is coming to you with a groin mass, but he is asymptomatic, you can leave it like that. You can have the conservative management, and if the patient becomes symptomatic, you'll go for the surgical repair. But if there's a pain and discomfort, and there's a mass as well, you have to go definitely for the surgical repair. And if there's a pain and discomfort, and there is no palpable mass, you go for the radiological investigations, and there's no evidence of hernia, then you go for the symptomatic conservative management. But if there is a hernia in a CT scan or ultrasonography, you have to go for the surgical repair. So this was about the management strategies as well. Now the question is, what kind of surgical repair you have to perform? It can be, in case of incarcerated or strangulated hernia, you have to go for the open repair. In case of unilateral, it can be a laparoscopic, or it can be open. It depends upon your expertise. And if it's bilateral, you have to go for the laparoscopy. And if there is a a recurrence of the hernia, you don't have to go from the fibrous tissue again. You have to go from a virgin plane. You have to go from the virgin tissue in case of the repair, because most of the time, if you go if for the repair from non-virgin plane, or you go for the repair from already fibrous tissue, obviously there would be adhesions, and there will be the surgical operation, or the surgical site won't be very much comfortable to you, or very much easy to you. So the treatment modality is basically the herniotomy. What you do is a herniotomy is actually you open the hernia, you reduce the contents, and then you pack it back, and you reduce the contents back into the peritoneal cavity. This is basically the principle on which you actually perform the herniotomy, right? There are different kind of surgical operations for that. There's an open suture repair, there's a Bassini's repair, there's a Lichtenstein repair, and there is a mesh repair as well. Most of the time nowadays, there is mesh repair because meshes are more easy. They're more friendly, they help in the wound healing as well, and they have a very, very low risk of recurrence as well. In case of open suture repair, actually what you do is you give the incision, you open the wound, you go down from the skin, you cut the subcutaneous tissue, you give a nick in actually that external oblique aponeurosis, and then you go down into the internal oblique, you split the internal oblique, you split the transversus abdominis muscle, you go deep down into the fascia transversalis, and then you go down into the peritoneal cavity, and then that's how you do it. But if case of the inguinal hernia, what happens is actually you give a nick actually, and most of the time it's a transverse skin crease incision, right? So what you do is actually you give the incision, you open the skin, you cut the fascia, you go down, and you reach the spermatic cord, right? And what you do is you separate the contents. You reach the spermatic cord because most of the time you have different type of the structures in the spermatic cord. It's the pemphiform plexus, it's the vas deferens, it's the testicle artery and the veins, and you identify the spermatic cord. You go because most of the time in the sac you have the spermatic cord in as well, and you in the sac you have the intestinal contents. You reach the extent of the sac, you go like to the deep inguinal ring, and then what you do is you reduce the intestinal contents, you pack the sac as well, you actually ligate and close the sac, and then the ring is basically closed, the sac is closed, the defect is closed, and then you suture the whole of the perineal cavity or the lower abdominal cavity, the groin region, in the layers, right? So that's how the open suture repair is performed. Basically, this is the open suture repair. You can see here. This is the hernial sac, this is the lipoma of the cord, and these are basically the contents of the cords. These are the pemphiform plexus here. You can see here this is the hernial sac, and most of the time it's reduced. And then the sac is again, you put the sutures here on the sac, and then you reduce it back. These are basically, this is the open suture repair. In the open suture repair, you don't put any mesh, or you don't actually put a flat mesh, or you don't go for a plugged mesh devices as well. You just have to close, you just have to reduce the contents, and you just have to pack the defect. You have to repair the defect, and you have to close it again in layers. So that was about the open suture repair. Bassini was the first surgeon who introduced this technique, and he actually performed this open suture repair. You can see here actually skin is open down, you goes down into the cavity, and the spermatic cord, you actually goes deep down, and the spermatic cord is identified, the sac is reduced, the sac is actually closed down again, and then that's the Bassini actually introduced to the open suture repair. It's not the mesh repair. The Bassini's repair is actually the open suture repair. This is the intra-abdominal muscle. You can see here external oblique. This is the external oblique aponeurosis. You give a nick in the external oblique aponeurosis, and then you goes down. You internal abdominal muscle, which is the internal oblique muscle. It is split off. And you can see here the preperitoneal fat and transversalis fascia. So the transversalis fascia, and then this is spermatic cord as well, you can see. This is the Popart ligaments, which is actually forming the inferior boundary of this inguinal canal. You can see here, this is external oblique hyponeurosis, this is internal oblique, this is the transversus abdominis, this is the fascia transversalis, this inguinal ligament. That's how the Bassini's repair is performed. There's another repair, which is the Lichtenstein repair. And in Lichtenstein repair, actually, you put the flat mesh. It's very much similar to the open repair, but the only thing is this: what you do is you put the flat mesh in the Lichtenstein repair. There are different kinds of meshes. There are chemical meshes, there are biological meshes, there are proline meshes. Actually, they are very much helpful. They're helpful in the wound healing as well. And there's a low recurrence rate with the use of the flat meshes. So almost open suture repair, it's no more performed anywhere. Most of the time, in most of the parts of the world, the surgeons are performing this Lichtenstein or the open flat mesh repair. But in case of the inguinal or in case of the femoral hernias, you place a plug mesh, which is the plugging of the mesh. But in case of the inguinal hernias, what you do is you put a flat mesh and you actually stitch that. What you do is you close the defect and then you put a mesh over the defect, and the mesh is then sutured up with the condyne tendon on one side and then one ligament on the other side. You can see here the defect was closed, and then now the mesh is being placed over that. The meshes actually will stick down, and there would be fibrosis as well, and there would be better wound healing than and the defect would be closed because the mesh will provide a strength to the wall, and there will be low recurrence rate. This is the type of the mesh we usually put down here, and we stitch the mesh or the suture the mesh with a condyne tendon and the inguinal ligament as well. You can see here this is abdominal layer, and you actually place the mesh over the defect. You close the defect, you seal the defect, you reduce the contents, seal the defect, put the mesh, and then close the abdomen in layers. Sometimes you have to put the open plug devices in the complex mesh repair as well. This was basically the deep inguinal ring. And what you do is you put a plug of the mesh, or you put a device or complex mesh into this deep inguinal ring, because actually, in indirect inguinal hernia, most of the time the hernia is coming from the deep inguinal ring. So you put a mesh over that ring so that the defect is actually sealed with a plug. And there's no positioning of a flat mesh over the defect. Instead, you put a plug or the device or the complex mesh into the defect as well. So you can see here, this is internal and external ring of the inguinal canal. You can see here this is internal, this is external, this is the scrotum. And what you do is, this is extremely large lateral and medial hernia. You can see here, which is called as a pantaloon hernia. And you insert the first mesh in the preperitoneal space. In case of the large hernias, and in case of the recurrent hernias, you put the mesh in the preperitoneal space. You can see here as well, it is basically the preperitoneal mesh repair, and you put the plug in that deep inguinal ring into the preperitoneal space. You can see here, first and second position mesh in the preperitoneal space as well. There's another approach which is called as totally extraperitoneal TEP approach. What you do is actually you stay in, you don't go into the peritoneum, you don't open the peritoneum, and you're just above, or you are just working in outside the peritoneum, right? So this approach is called this totally extraperitoneal approach, and you this extraperitoneal approach is a preperitoneal approach. You don't enter into the peritoneum. Actually, you just reduce the contents back, and then you put the mesh over that particularly. That is called as total extraperitoneal approach as well. You can see here, this was an indirect inguinal hernia, and this was a direct inguinal hernia. But you don't go down into the peritoneum, and you put the mesh in the preperitoneal space. Sometimes the hernia is strangulated and the hernia is obstructed as well. So strangulated hernia or the obstructed hernia is basically it's basically the emergency. So in case of the emergency, you have to go for the laparoscopic surgery as well, because sometimes the hernia is strangulated and you have to insert the laparoscope. You have to go for the inguinal hernias. You actually reach the sac, you open the sac, you reduce the contents through the laparoscope, and then you suture it again, and then you close it again. This is basically a laparoscopic inguinal hernia surgery. So there can be different complications of the inguinal hernia surgery. There can be early pain, there can be bleeding as well, there can be a urinary retention, because sometimes inguinal hernia is actually on the medial side of the hernia is a urinary bladder. So sometimes because of the irritation to the bladder or injury to that, there can be a urinary retention. There can be anesthesia related complications. There can be a seroma formation. There can be wound infection. There can be late chronic pain, and they can be a testicular atrophy. So you have to look for all these complications. There can be early pain, bleeding, urinary retention, anesthesia related complications. There can be formation of the seroma. If you don't put a drain inside, then there can be a formation of the medium seroma. There can be a wound infection. There can be a late chronic pain, and there can be a testicular atrophy. So you have to look for all these complications as well. So now let's talk about the femoral hernias. Already told you that we have talked about the inguinal hernias, and the inguinal hernias are above and lateral to the pubic tubercle. You can see here basically this is the symphysis pubis, this is the pubic tubercle, this is the anterior superior iliac spine, and this is the inguinal ligament. Actually, the inguinal ligament is running from the anterior superior iliac spine to the pubic tubercle, and the hernia which is lying above that is above the pubic tubercle, above and lateral to the pubic tubercle is a inguinal hernia. But the hernia which is located medial and below the pubic tubercle, that is called as a femoral hernia. And the femoral hernia is actually coming from the femoral canal. If we talk about the contents of the femoral canal, we have the femoral vein, which is the most medial, then we have the femoral artery, and we have the femoral nerve. So these are basically the structures which are located in the femoral triangle, and these are very important structures which are located in the femoral sheath. So femoral vein, then artery, and then nerve from medial to lateral. These are the structures which are located in this. And most medial to the vein are the lymphatic, which are called as cloquet nodes. So this is the site of the potential weakness. The nodes of cloquet, they are basically the site of the potential weakness, and the hernia is coming from that. So if the hernia is below and medial to the pubic tubercle, this is called a femoral hernia. And if the hernia is above and lateral to the pubic tubercle, this is called as the inguinal hernia. So you can see here, this is the inguinal ligament running from the anterior superior iliac spine to the pubic tubercle. You can see here, this is hip bone, this is a small intestine, this is the ligament, and this is the femoral hernia. And these are the femoral vessels. You can see here, this is the vein which is medially, and this is the artery which is laterally. But here, most medial to the vein are the cloquet nodes, and hernia is actually coming from that side, which is medial to the vein. So the femoral hernias are much more common in the females as compared to the males as well, and they have a very narrow neck. I have already discussed in my previous lectures that whenever the hernia has a narrow neck, it has more chances to be strangulated. So the femoral hernias, they have a very small, very narrow neck, so that's why they can be strangulated, they can be obstructed, so they can you have to go for the emergency herniotomy if they are strangulated, because there's a more risk of strangulation and herniation because of their narrow neck. Right? So, how you're going to make a diagnosis in case of the femoral hernia, already told you. You have to examine for the direct inguinal hernia. You have to look for the saphenous varix as well. You have to go, it can be a femoral artery aneurysm as well. So, how would you going to differentiate between a hernia and the femoral artery aneurysm? Because most of the time, the artery, if it's an aneurysm, there would be a bruit. You have to listen for the bruit as well. There can be a bruit in case of the femoral artery aneurysm, and if it's a saphenous varix, you have to try to compress it. And if it's a non-compressible, because the veins are non-compressible, there can be a psoas abscess as well. So you have to go for the ultrasonography, which will tell you about the femoral artery aneurysm, saphenous varix, or the psoas abscess. You have to go for the CT, and you have to go for the MRI as well. And there can be a rupture of the adductor longus muscle with a hematoma. So these are the differentials that should come into your mind when you're examining a patient with femoral and inguinal swelling. So this was about the diagnosis. Let's talk about the investigation. As I have already told you, we go for the ultrasonography and CT scan, because you can differentiate between a metastatic lymph node or saphenous varix, or the hernia and the hernial contents as well. So this was about the investigation. Now let's move towards the surgical options we have in case of a patient who is coming to you with a femoral hernia. One is a low approach, the other is the inguinal or the Lockwood approach, and the third is a high approach. So first we'll talk about the low approach. Low approach is very easy. It's for the uncomplicated, or those hernias which are not strangulated or which are not obstructed. In case of the simple femoral hernias, you go for the low approach. You give a transverse skin incision. You can see here that this is basically the hernial sac or the swelling, and then you give a transverse skin incision under the local anesthesia. And then what you do is you open the skin, you goes deep down, you split the muscles from the transversal phallus fascia, you go down into the sac, and then the sac is identified, the sac contents are being reduced, and these are the sac contents being reduced, and this is the opening which is being stitched back. The sac is closed, and then you have to after closing the sac, you have to basically close the abdomen in layers. This is a very simple approach. This is called as a low approach. Now we'll talk about the inguinal approach, which is also called as a Lockwood approach. First of all, what you do is that you initially, this incision is basically very much related to the Bassini's repair or the Lichtenstein operation. You mobilize the spermatic cord, then you transversalis fascia is being opened from the deep inguinal ring. Hernia is reduced by pulling and pushing, and the neck of the hernia is closed with the sutures or mesh, and then the layers are closed just like for the inguinal hernia. So in case of the Lockwood approach or the inguinal approach, you give the initial incision just like the Lichtenstein or the Bassini's. You split the you cut the external oblique epineuritis. You split the internal oblique and the transverse abdominis muscles. You go deep down. You go for the dissect the transversalis fascia. You go deep down. You identify the spermatic cord, mobilize it. Transversalis fascia is opened from the deep inguinal ring, and the hernia is reduced by pulling and pushing. Neck of the hernia is again closed down with the sutures are measured, and the layer are basically closed. But in case of this Lockwood approach or for the femoral hernia, you actually put a plug, basically the mesh plug, into the deep inguinal ring, and you close the sac. So this was about the inguinal approach. We're going to talk about the high approach as well. This is basically used in emergency where high risk there is a high risk of bowel strangulation. It uses the regional or the general anesthesia. And actually the incision is being made into the lower abdomen, and the horizontal skin crease incision is made. Anterior rectus sheath is incised, and then when you incise the anterior rectus sheath, you displace the rectus muscle medially, and you proceed deep to the muscle into the preperitoneal space. Hernia is reduced. Sac is basically open to allow inspection, and the contents are being reduced. Femoral defect is closed with the sutures, mesh, or plug. So this was about the high approach. You can also go for the laparoscopy as well. So let's talk about the relationship of inguinal and the femoral hernias. I have already emphasized on this thing before, again and again in my different slides, that actually femoral and inguinal hernias, they're very much closely related to one another. One is, like, if we talk about the femoral hernia, it is medial and below the inguinal ligament or pubic tubercle, and the inguinal hernia, it is above and lateral to the pubic tubercle. So you can see here that this is the pubic tubercle, and this is actually the pubic tubercle, and this is the iliacus muscle. You can see here in the diagram as well. And this is the femoral nerve, this is the femoral artery, and then we have the femoral vein. You can see here that nerve is lateral, artery is between the nerve and the femoral vein, and the femoral vein is most medial. And here, this is the most medially, you have the cloacoid nodes, and the sac of the femoral hernia is coming from that cloacoid node side. So you can see here, this is medial to this pubic tubercle, and this is the deep inguinal ring. These are the inferior epigastric vessels, and this is the superficial or external inguinal ring. Here is the pubic tubercle. So the inguinal hernia is lateral and above to this. Inguinal hernia is above and lateral to the pubic tubercle, and femoral hernia is below and medial to the pubic tubercle. So there can be other swellings as well in the inguinoscrotal region, right? So this is something very important to know. In case of the inguinoscrotal swelling, and this is basically not a scrotal swelling. You have to differentiate from the inguinoscrotal swelling and the scrotal swelling. In case of the inguinoscrotal swelling, you cannot get above the swelling, right? Like, you can palpate the inferior margin of the swelling, but you cannot palpate the superior margin of the swelling. You cannot get above the swelling in case of the inguinoscrotal swelling, because it is coming deep down from the abdominal cavity. So not possible to palpate above and feel the swelling. But in case of true scrotal swelling, you can palpate and get above the swelling. It's possible to palpate above and feel the swelling, because it's a very defined and enclosed swelling. So you can get above the swelling in case of true scrotal swelling. But in case of the inguinoscrotal swelling, it's coming from the abdominal wall, so you cannot get above the swelling. So that's how you can differentiate between inguinoscrotal swelling and in case of the true scrotal swellings. So what comes in your mind if we talk about the inguinoscrotal swelling? It can be encysted hydrocele of the cord, it can be a vaginal hydrocele, and it can be a spermatocele as well. I already told you that actually when the testes descend down from the abdominal cavity, there is a layer of the peritoneum which is coming down with its, and the layer of the peritoneum is called as a tunica vaginalis. But sometimes this layer goes off, and sometimes what happens that the fluid accumulate in this cavity in the process of vaginalis. So that's called as a hydrocele. It can be an encysted hydrocele of the cord, it can be a vaginal hydrocele, you can see here, or it can be a spermatocele as well. There can be a torsion of the testes. Sometimes this is the right testicle, this is the left testicle. Sometimes there can be a medial or lateral torsion of the testes. But the torsion of the testes, this is extremely painful. The pain is actually out of proportional, and you try to give so many analgesics to the patient, but the pain is usually not responsive responsive. So in case of the torsion is the emergency, and you have to shift the patient urgently to the operation theater, and you have to perform the surgery, because actually in torsion of the testes are actually they're twisted around the cord. So that's a surgical emergency. So it can, in case of inguinoscrotal swelling, it can be a torsion as well. And if we talk about, it can be a testicular tumor, it can be a epididymoarchitis, it can be hematocele, or it can be a varicocele as well. So I will discuss all these things in my other lecture when we talk about the genitourinary system. But right now I'm just telling you only the names of these things, because these are the inguinoscrotal swellings. And when you are examining a patient for inguinal or the femoral hernia, these things should come in the differential diagnosis, like it can be spermatocele, the hydrocele, encysted cord of the cele, hematocele as well, varicocele, or it can be testicular tumor or epididymoarchitis. You can see here as well. So this was all about the lecture, and I hope this was a nice lecture and help you better understanding. Thank you for watching sqadia.com.